can invite the next set of chairpersons, Dr. Abhinav Sharma and Dr. Ajay Sharma, to define what exactly is gallbladder incidental cancer.
So, for the next talk will be definition of the incidental gallbladder cancer. For this, the chairperson, Dr. Ajay Sharma, I request. Dr. Ajay Sharma is a professor and head Department of Surgical and Gastroenterology, Mahatma Gandhi Hospital. I request Ajay sir to call lead presenter on the dais.
For this session, we have Dr. Abhishek Agrawal. He is the assistant professor of GI surgery and liver transplant at Amrita Institute at Faridabad, Delhi. So he will be speaking on incidental gallbladder cancer, definition of the incidental gallbladder cancer. So I think Abhinav is not here. So in the meantime, we can start.
Good morning, esteemed faculty and my dear colleagues. So I'll be talking about the definition of incidental gallbladder cancer, what it is and what it is not. Greetings from Amrita. So just imagine a routine surgical procedure aimed at addressing gallstones and related issues, only to unexpectedly encounter a hidden threat, the gallbladder cancer. So as we know now, the symptomatic gallstone disease comprises the major load of a surgical OPD, and North India has higher incidence of gallstones as well as gallbladder cancer. The widespread use of ultrasonography has only increased this detection of cholelithiasis, and consequently the cholecystectomy rates have gone up, so much so that it is now the world's most commonly performed surgery across the world. Historically, the coexistence of gallstones and gallbladder cancer has been known for ages. In 1931, Evarts Graham observed that gallstone was present in 70 to 100% of cases of gallbladder cancer, and gallbladder cancer was found in 4.5 to 14% of patients with gallstones. Classical surgical teaching has been that 1 out of every 100 specimens of gallbladder removed for a benign pathology may reveal an incidental gallbladder cancer, although the rates that are reported are much lower. So gallbladder cancer may present as a metastatic disease, it may be an advanced inoperable disease, it may be a resectable mass-forming disease, or incidental discovery on histopathology for a simple cholecystectomy specimen. It is this latter category that is termed as incidental gallbladder cancer. Some authors may also ascribe the finding of intraoperative finding of a malignancy which was subjected to frozen section as incidental gallbladder cancer, although this definition has its fallacies. So there are different terminologies ascribed to the same: inapparent, unexpected, unsuspected, missed, or truly incidental. So are all these the same disease? All aforementioned terms do as a whole either take preoperative, peroperative, or postoperative diagnosis as histopathological examination. So if we do the literature review, we see the American College of Surgeons, as a part of their study for National Surgical Quality Improvement Program, they considered only postoperatively detected patients as a part of incidental gallbladder cancer in this study published in 2014. The ICMR consensus paper for management of gallbladder cancer also only took into account the histopathologically found gallbladder cancer to be the actual incidental gallbladder cancer. And another meta-analysis done from South Korea also took only the patients who were identified post-operatively detected cases to be incidental gallbladder cancer. Dr. Kapoor, in his chapter on incidental gallbladder cancer, took resected gallbladder specimens to be having an incidental gallbladder cancer. Another paper from Dr. Varshane's group from Bhopal also had only the specimen of gallbladder which was possibly secondary to a benign pathology and revealing a cancer to be taken as incidental gallbladder cancer. The Brazilian consensus paper also mirrors the ICMR consensus paper in only taking the specimen which was done for a benign pathology and subsequently revealing a gallbladder cancer to be incidental gallbladder cancer. Dr. Bastianen from Netherlands described incidental gallbladder cancer as a histological surprise, which probably is the most abridged definition that we can think of to be an incidental gallbladder cancer. However, there are few papers, such as another paper from Seoul, from Choi et al., where the gallbladder cancer suspected during the surgery as well as after the surgery was considered to be incidental gallbladder cancer. Similarly, from the study from MD Anderson group, also concluded the incidentally found intraoperative gallbladder cancer to be considered as a part of their study. However, even though we are on the both sides, from France, they considered only histopathological examination. Another study from North America also took pathological assessment following cholecystectomy as to be the real gallbladder cancer. So another terminology is missed gallbladder cancer. This was described in a recent paper from PGI Chandigarh group to be having either a preoperative suspicious finding, an intraoperative suspicious finding, or a finding which was missed even on post-operative histopathology, and the patient presents within 1 month with some distant metastasis. Dr. Bihari and Dr. Kapoor in the paper told that it actually is a misnomer, and the actual missed gallbladder should be ascertained only to those cases where even after a histopathological examination following a routine cholecystectomy, patient has presented within 1 month with distant metastasis. So this lack of uniformity in definition may lead to a lot of confusion, both in terms of management, the consensus, and also research. So what we propose as a part of this study is to have a uniform definition of incidental gallbladder cancer, which is the gallbladder cancer found in gallbladder specimen after surgery for a benign gallbladder condition without any preoperative or intraoperative suspicion of the same. We also should define the missed gallbladder cancer, which is the gallbladder cancer reported in a specimen or missed from reporting in a specimen, even though there were signs of cancer before or during the surgery. Thank you.
I think it was really a very good presentation, and I think Abhinav has joined. Abhinav, can you come on the stage, please? He's a co-chairperson with me. So I agree that having a definitive term to label it as an incidental gallbladder cancer is really difficult, because it has been widely used. Most of the times we have a sonography finding which shows an irregular gallbladder wall thickening. The patient undergoes a laparoscopic cholecystectomy and the gallbladder is not seen by the surgeon, and then subsequently sent for histopathology, and the pathologists take one specimen, one cut section, and there is no malignancy to it, and the patient comes with metastasis. But actually this patient had gallbladder cancer pre-operatively, which should have been diagnosed. So this is not a missed gallbladder cancer. So, and moreover, once you see the specimen, I think which this is the classical training for all the surgeons, that once you do a lap chole, you should see the gallbladder on table before you extubate the patient from anesthesia. So it is mandatory. Until unless you have seen that gallbladder, I think it is not correct that you extubate the patient, because if you find a lesion, this is a time when you can do something which is required at this point in time. So definitely there is a lot of overlap in the definitions. Abhinav, will you like to add something to it?
So is a frozen is of value on the table? If you have any suspicious finding, you open up the gallbladder, you see a lesion, a suspicious lesion.
It can be used to confirm, but then it will not be an incidental gallbladder cancer. That is what we want to tell. If intraoperatively or on just before the extubation, when we are opening the specimen, we find that there is a lesion, then it should not be termed as an incidental gallbladder cancer. It should be a missed, because some finding has been missed either preoperatively or intraoperatively to find the gallbladder cancer.
Yeah, can we call Shraddha on the desk? Shraddha is a hepatobiliary surgeon of surgical oncology from Tata Memorial, Mumbai, and she will be presenting her comments on this session, and then subsequently we can have questions from the open house. Shraddha,
I do not have a presentation, but I would like to summarize what Dr. Agrawal has very lucidly said in his presentation, that there is lack of uniformity, just because everybody's interpretation of what constitutes incidental gallbladder cancer varies. We all agree with the fact that we need to do something to identify these patients so that we don't see a lot of incidental gallbladder cancers in our practice. Because unfortunately, all of us are faced with scenarios where we see patients who've probably had a diagnosis which should have been picked up earlier, and they present to us with metastatic disease, and this is a scenario which we want to avoid. What can be done to pick these patients up is what we have to reach at in this meeting, probably at the end of 3 days, where we'll be able to once we have defined, now that we have defined and we all agree that this is the ideal definition of incidental gallbladder cancer, let's now strive to see what we can do to increase the incidence, because in our practice, if we've operating 100 patients of gallbladder cancer, 50% of them would be incidental. I'm sure that would be the practice around the country. We can take each and everyone's opinion on that. And as Dr. Agrawal nicely summarized, that the true incidental gallbladder cancers are ones which are detected post-operatively on histopathology, where we have operated thinking that it is a presumed benign condition, and that it's truly a surprise and not something which is missed pre-operatively.
So, Abhinav, we can have, Abhishek, we can have you on stage, please. So, so what is your opinion if you have a thick wall gallbladder, patient undergoing cholecystectomy, patient is having thick wall on sonography,
So
uniform thick wall gallbladder?
uniformly thick wall may not be in classical teaching ascertained to have a gallbladder cancer unless there are some signs, but a focal thickening or which is unusual, that may be more ascribed to having a gallbladder cancer.
We have now two, Dr. Kapoor is on stage. We can have mic with Dr. Sadiq and Dr. Saraswat. I think it will be a good discussion now. We have, yeah,
So
Dr.
Abhinav,
Kapoor.
Abhishek and Shraddha, you are the most important people in ISG GBC, because you have to define what are we going to talk about. So we have to be very clear, and your group includes other persons also. Dr. P.K. Mishra, who is one of the senior GI surgeons, he was not able to come because of a family commitment immediately after this meeting, but he's been contributing to your manuscript. And I think we need to be very clear, the scenario which Dr. Ajay asked, thick walled. In my opinion, as soon as you see a thick walled GB, whether it is diffuse or uniform, it becomes a suspicion. So that should not be clubbed with incidental. Similarly, the point which Dr. Abhinav was trying to ask about the role of frozen section. Obviously, you will not do frozen section in all gallbladders. You will do only if you see something in the specimen. So the surgeon opens the specimen and there is a suspicious area. The moment there is a suspicion, it becomes a suspicious gallbladder cancer. So I have been saying, and my colleague Dr. Anu Bihari, we have been saying, and I think as you projected, most groups tend to agree with this, that the true incidental gallbladder cancer, and that I feel should be the definition for this group, is when even the specimen opened by the surgeon or by the examined by pathologist looks normal, but histopathology shows malignancy, that and that alone should be classified as incidental gallbladder.
So,
Yeah, first Dr. Sadiq, please. Sadiq.
see the reason to define this is there a different disease? So for example, as we discussed, we'll go one by one. So we see a lot of thick walled gallbladder. Now what do? You treat them or with suspicion of gallbladder cancer straight away. That means the burden of suspecting gallbladder cancer increases many folds. This may vary in various parts of the country and may take different outlook if you are working in a certain part, whereas you're working in another part. So that part needs to be segregated from the part that where you have on histology. If you see intraoperatively there is a problem, why is it any different from that gallbladder cancer, different from incidental gallbladder cancer? Till now there was no suspicion of that, and now you're just seeing. If you had not seen, it would have gone there. But are they two different diseases? So if you find on the operating table and detect it, it becomes something else. So therefore we have to segregate them. So that's the key question, that we need to segregate patients into groups which have different outcomes or different management strategies, rather than just say by definition only if it is on histology. So how do we where do you put this? Suspected gallbladder cancer, is it any different from incidental gallbladder cancer?
Suspected and missed are different from incidental because they differ in terms of their outcomes as well and the management that we can offer to the patient.
Intraoperative, till now nothing. Open the specimen, you find some focal thickening, and you say, oh, I need to do histology. So my question is that a different disease than what you see on true incidental gallbladder cancer? And if that is the case, then there is a point in differentiating between these two.
So, very good question. Unfortunately, we don't have data anywhere from the world where we can say that the true incidentals, whether you detect them post-surgery, actually are biologically different. I think there is a session to address this question itself in the conference, and we just had a publication accepted today morning in which we have looked at outcomes of patients who are just T2 gallbladder cancers, which are resected upfront versus those which were incidentally detected. It's a series of around 400 patients, and we've shown that patients who have incidental gallbladder cancer detected, which are stage matched, tend to have poorer outcomes. Hopefully, I'll be able to share the manuscript once it is online. But till now, there is no data which has compared head to head, and I don't think we will get that answer with any kind of trial or retrospective studies. We just have to pool data and probably arrive at a consensus to see whether this actually behaves differently.
Shraddha, if I am correct, I am taking it correctly, it is the patient who is having a poor prognosis is the one who has now been diagnosed on histopathology,
Yes.
but he was fine intraoperatively.
Yes.
And if he is diagnosed intraoperatively, they will have a better prognosis.
Better
That's what you want to
prognosis,
say?
yes.
So do you mean to say that if it is done at the same sitting, the surgery is done in one sitting, it has a better prognosis?
Yes.
Is that you want to communicate?
Yeah.
Okay, so maybe Dr. Saraswat sir has a question. Sir, can we pass the mic to Dr. Saraswat, and then we can pass on to the, yes.
I think the consensus seems to be that incidental gallbladder cancer is something discovered at histopathology post-operatively, and nothing pre or intra-op would qualify. Now, when you say that, then discovered pathology depends very much on how extensive or how thoroughly the gallbladder is examined. So to diagnose incidental GBC and not make it missed incidental GBC, what is the consensus on how thorough should be the gallbladder examination? Proper gallbladder mapping by sectioning the entire gallbladder specimen and looking for it by what techniques, etc. So what is the consensus on that? And probably that would be a major part of what this group would have to contribute.
Yes, actually, Dr. Mathur said that pathologists should be a large chunk of the audience here. If we have anybody, we can get Madam to comment.
Yes, we have a pathologist, yes. Now, I would like to emphasize here, we have now two types of pathologists which are normally categorized. One is a routine pathologist which will be doing a routine histopathology for a routine gallbladder which comes to him, and another one will be who is doing a oncopathology. So these will be two different groups. Our main work should be on the routine pathologists who get the routine gallbladder. How should they examine? Because oncopathologists will anyway take 50 specimens out of that. But how does a routine? So maybe I think she'll be able to better comment on that.
I think the index of suspicion should be more for every case, for every college. For every gallbladder specimen, the index of suspicion should be high, and then it should be thoroughly examined. It should be opened properly. It should be opened from the cystic duct to the fundus, and then each and every corner should be examined properly. Most of the times we don't have suspicion, and then we overlook and we take sections without, maybe sometimes without opening or without properly opening, without seeing every corner. Sometimes there are diverticula, or there are due to chronic cholecystitis, there are sometimes folds or there are adhesions within the gallbladder itself. Then some folds are not opened, and then we need to see it clearly, and many a times a stone blocks some part of the gallbladder. Then we need to see that area, and that may harbor carcinoma.
So if we are taking you correctly, meaning to say that you should either take more number of specimens from the same gallbladder, and
Also, it should be
second,
thoroughly examined, and even a subtle thing.
there are two parts of thoroughly examining. One is,
should be taken into consideration, and then sections should be taken.
suppose gallbladder is normal for you, once you have opened it, how many sections do you take from one gallbladder as a routine, not for malignancy? Now your routine gallbladder, simple cholecystectomy being done, patient had no history, wall thickness was normal on sonography. How many sections do you take routinely for this gallbladder?
We routinely take 3 sections.
You take 3 sections.
Yes.
So is that consensus correct on three sections? What do you think now? Sir, we have Dr. Mathur, he has to say something. Then we have Dr. Sadiq,
So,
and then we have comments. Yeah.
Yeah, so many of these questions our study will answer. You know, we are looking at pre, peri, post. Surgeons' views, intra-op views, ultrasound views, other imaging techniques, histopathology, outcome, survival. So I'm trying to build a story. And I see IGBC as a continuum to frank gallbladder cancer. And I don't have reasons to believe they will behave biologically different. Okay. So I don't know whether Prasenjit is here, but I saw his name in the agenda.
No, he'll be coming today.
So we have set up quality assurance mechanisms for pathologists. And this study is being done in routine medical colleges. We have not taken onco hospitals. These are routine surgeons who do routine cholecystectomies, routine pathologists who do routine reporting. When blocks are sent to Prasenjit from these centers, our pickup rate has improved for IGBC. They were missing. So we will be publishing this protocol on how pathologists, I think our committee has recommended 12 strips from each gallbladder. So it was a committee of around 8 or 10 pathologists who have sat down together and said, as a study, this is what, and it has improved our pickup rate, particularly the hand-holding which is being done for routine pathologists. So our focus should be on routine pathologists because the chunk is not done in academic institutions anymore. The chunk of cholecystectomies are being done outside academic institutions, and histopathology is an extra burden financially. So, I mean, you know, that's the problem we are grappling with.
I think point well taken that at least 12 sections should be taken from a routine gallbladder for any histopathology. Ma'am, want to say?
One more, that's the most, I think one of the most important points is that most of the times this sampling of the gallbladder specimens are usually done by residents or junior pathologists who don't have the experience, and then they just open it. They think that it may not be happening. It's a routine surgery. It's the most common surgery. So it's being done for chronic cholecystitis. Most of the times we get it chronic cholecystitis. Unless we take sample from a specific region, we cannot, even after reviewing the slides, even after reviewing the blocks, we cannot get gallbladder carcinoma unless it's sampled from the proper end.
Yes, I think we agree with what you are saying. Same thing we happen to face as a surgeons, that the lab call is being done by the junior consultant, junior most resident in our team, being thinking that it's a routine surgery. He does not open the specimen. So it is not a fault on him. It's my fault that I don't take that responsibility. I think we can have more questions from the audience.
There is a different twist to the story I want to bring here.
That will be interesting.
We agree that the prognosis of a truly incidental gallbladder cancer may be different, or the outcome or the survival curves may be different. But isn't the idea here to identify a CA gallbladder that should have been identified in the first place and not missed? I think that is also an overriding thing. Till now, whatever data has been published, so-called incidental gallbladder cancer, we don't know the preoperative characteristics or the radiology, how meticulously these things were assessed, and then how well the pathology specimens were assessed. So truly incidental to my mind becomes where you have ruled out every clinical suspicion of a malignancy on pre-op history, examination, etc., where you have a to-the-point ultrasound or imaging that says that there is no suspicion that this may be a thick-walled or a possibly malignant gallbladder. The surgeon has opened the gallbladder and not just inspected but also palpated. And I think it's very important that after inspection and palpation, the surgeon should point out with a suture or inking that this is where the problem is, so that the pathologist can see, and a proper pathological examination. So when we look at the previous studies or the reporting or the nomenclature for IGBC, how many studies have actually done all of this?
I agree. Yeah, please.
The early lesions where muscular invasion is not there, they will be difficult to pick up on simply by palpation. So we have to devise the ways of looking at gallbladder grossly under dissecting microscope or maybe some other modality to identify in situ lesions or early lesions which are truly incidental gallbladder.
I think that point has already been asked by Dr. Sadiq, that what is the difference between diagnosis and prognosis between the two groups. Prognosis has already been asked. If Shraddha or Abhishek want to take anything, comments on that
we
before we
agree
go to
that,
the question?
I mean, it's a utopian world where you would have the ideal imaging done and ultrasound to the point by an expert in the field. We have a study from India which has defined criteria like GB-RADS, where they've given specific points which have to be looked at, and the specimen being opened, palpated. But unfortunately, this
I think Dr. Kapoor has said, and then subsequently histopathology. I think we'll have in subsequent discussions this thing about PET-CT. Dr. Rajgovind sir?
Can we have a recommendation for the future that we take photographs of all the gallbladder cancers opened up? Now that we have face recognition, AI coming in a big way, probably if we give 1,000 images of gallbladder pictures, AI would be able to tell that this is there. So we can make a recommendation that after you do surgery, just take a photograph, and we have a database of all those photographs.
Yeah, this is actually happening in endoscopy.
As a missed gallbladder cancer should be ones which we miss even on the histopathology. So let the benchmark be histopathology rather than the preoperative ultrasound. Just a short one.
So, Abhishek, you would like to take that?
So what you just said, I actually presented two different papers. One was from the PGI group, in which they counted even the on-table finding after the specimen is removed as one. But another paper by Dr. Bihari and Dr. Kapoor said that actual missed is the one which is even missed on a histopathology. And a patient is presented within 1 month with distant metastasis or spread. So actually that should be considered as missed, because you have lost the chance of detecting it preoperatively, intraoperatively, as well as postoperatively. And now the patient is presented with distant metastasis.
In simple language sense, missed, it would be right. Definitely we have missed the opportunity.
Correct.
But in scientific term, like we are in a scientific meeting, should we not label it as unsuspected gallbladder cancer?
If you're finding a thickening, it should be rather labeled as a suspected gallbladder cancer, pending a histopathological confirmation, because we have found a thickening there.
So again, I would prefer, we would prefer that suspected should be something based on the preoperative imaging, and intraoperative we would prefer to label it as unsuspected gallbladder, which we were not suspecting preoperatively, and we found it intraoperatively either before completion of cholecystectomy or after completion of cholecystectomy while opening the gallbladder specimen. So
I think it is interesting. We have a lot of semantics into it, which can be a lot of words. I think we need to define them. That is what the purpose of the meeting today is. What is unsuspected, suspected, missed, found, incidental, intraoperative, detected? I think they need to be defined so that we have better things. So I think we can have questions. Yes, please.
So, I mean, the problem we are discussing is we want to get the maximum out of that big volume, right? And then you want to say that it has to be uniform reporting. So gallbladder ultrasound would be reported by various people at various places. You can't make a uniform method of expertise available at each place to detect finer details of that, right? And then you say that at the end of that, none of those should be there. So then only we will deem it as incidental. We know that in incidental, it is not only PT1, it will be PT2, PT3, right? So that means they have had some indication which were not picked up, but that doesn't mean it becomes a missed gallbladder cancer. The second point which I want to say, as Dr. Sumaya said, that junior most does it, or somebody who's not well versed with it does the pathology. But that's the real case, life scenario. Gallbladders will be examined everywhere, and you don't expect expert pathologists to be looking at gallbladders all the time. And another real life scenario is you don't remove a complete gallbladder most of the times during a cholecystectomy. If it is a thick-walled gallbladder, if it's an acute gallbladder, you split the gallbladder and take it out. Now it's not a complete gallbladder. Sometimes we have various strips of gallbladder. How do you examine that gallbladder? So, you know, all these things have to be kept in mind. So the definition has to be simple, overall, uniform, irrespective of who's there. All other things we should leave away. The point about how much to examine should be uniformed. I mean, it should be defined now. That then only you would say it is the incidental gallbladder cancer. Otherwise, you may not pick up as everybody's experiences. And I personally feel that at the table, if you detect that, it should be the same as incidental gallbladder cancer, because till now you have not picked up. And as a matter of fact, we will discuss when the time comes for discussion that I don't believe that opening on the table makes a big difference, because there are various other considerations offering treatment at that time to the patient on the operating table. You don't have consent, you don't have information to them, they have come for a simple daycare surgery, you suddenly tell them, and there's no suspicion, mind you, and you tell them, oh, you're going to undergo a major operative procedure. And is that right? So those things we can discuss at that time. So a big thing is made about opening the gallbladder and finding out. I think you do a safe gallbladder operation, it is not suspected, you subject it to histology, and then take the steps from there what you get.
Okay, we can take a next question, please. Yeah.